And obviously, we need to have the individual in front of us and their individual circumstance and individual sort of findings. But if we break it down into what sort of tools do we have available, and tools we mean what can we prescribe and what sort of advice can we give? And so if we've identified that it's a binocular visual dysfunction or an accommodation problem, which implies that it's out of whack with the binocular visual system, where we're comfortable that everything else about the person's visual system is healthy and everything looks okay, then we talk about, okay, well, a lot of the headaches that you might get from binocular visual dysfunction is the sheer amount of near work that you're doing. And so let's have a discussion around simply just that, so taking breaks frequently. And we've talked about this on other videos, is that, there's a cute rule, the 20-20-20 rule, which is every 20 minutes, look away 20 feet for 20 seconds. Now, it sounds great, and I think it's good advice, but it might have its limits on the practicalities. And so I certainly think that if you wanted to get a longer period of time for getting some work done, if you go 45 to 60 minutes, but then take a decent 5 to 10 minute break, is some general advice around trying to avoid both tension headaches and vision headaches, because you're getting moving again, basically. And so that's one of the things we look at is breaks. Have you got good lighting? How far away is your screen? Looking out for, how is your workstation sort of set up, and those sorts of things. So you've got those things that the person can take control over, is how much intensity of work are you doing in one moment, and what adjustments can you make to manage that. And then we look at, well, what tools are available from a prescription point of view. So let's assume if you've got a mild refractive error that we think is contributing to headaches, and we'll talk about prescribing that. We may find that certain types of binocular visual dysfunctions do benefit from like a mild reading prescription, and people worry that makes their eyes weak and dependent, and I simply don't see that happening. Because the way I look at it, that if you are careful in the way you prescribe those kind of lenses, they're a bit, I call them the ergonomic chair for the eye. They're basically providing some assistance to make the near task more comfortable, and that you might only need to use it for those intense kind of near tasks. So that might be something that we would consider based on the individual circumstances. And then we would tend to, in our practice, we would tend to use vision therapy for someone where the dysfunction has gone far enough that taking breaks is not going to work. Prescription's really not going to do enough, and then we have to effectively rehabilitate and have someone develop better visual skills again. It could be that some people didn't develop them properly to begin with. Someone might have had a mild whiplash, mild concussion, not realised it's created this. Sometimes it's just created from doing lots of near work, and it gets to a point where they're kind of stuck, and using different analogies for different things. I've got my ergonomic chair analogy. The other one is that, and take personal experience, busted my knee at 19. Developed a change in the way I stand and the way I walk because of it. The injury is long gone. I'm certainly not a 19-year-old anymore, but the patterns of how I move and how I stand still persist. And so in order to change that and get back to a more balanced way of standing and sitting, I've got to do some active rehabilitation. And so sometimes what happens and the change in function can go too far, that we need to do something a lot more active to rebuild it and put it back to something more normal looking.
Now, are prism lenses also part of your toolkit? And I think you've got some strong thoughts about prism lenses. So first of all, can you explain what they are, and then whether you don't use them?
I've probably got some samples in. Prisms look and sound simple in theory, or in sort of just looking at them. And so you would never prescribe something looking like this. But and for those of you who are into music or old, you might remember the Dark Side of the Moon, Pink Floyd cover, where you see the prism breaking up light, and certainly you can sort of set up a situation where white light's broken into rainbows, but in much smaller amounts, much smaller degrees of prism, you don't quite get that kind of impact and effect, particularly if you put it within a curved lens. But effectively, what a prism does is bend light one direction. And one of this will work here, but if you can look at the computer monitor on this side, see if I can get it to work, where the direction of the prism, I might actually go something smaller, might work a little better, where you can see the stand has been pushed sideways. Right. Okay, that little section of stand in there is pushed sideways. And so it's bending light in a particular direction. So it bends light towards the tip. So if we're prescribing a lens with the thick part towards the nose, okay, then the light is being pushed that way. And so I have to make a movement of my eyes that way to bring the alignment back together again. So one of the theories is, if your eyes are doing this to begin with, we can pop prisms in to match. Now, there are certain circumstances where that works quite well. And so if you've got a vertical imbalance, okay, we don't have as much movement this way, prisms in particular can be quite useful in that sort of situation, where someone can't bring their eye down, so you bring the world down through the prism, and now I can get the two eyes working together well again. There is a lot of toing and froing in the research about whether horizontal prism for eye teaming problems that are more regular, the convergence excess, convergence insufficiency, are all that useful, because we often see a situation where people eat prism, where we kind of go, well, you come in, we prescribe a certain amount of prism. It seems good initially, but then you come back later needing more because we haven't got to the heart of the problem. And then there's other things that go into that. Once you start getting up into high prisms amount, they look really simple. They're these flat things. They've got two surfaces. They push the light that way, but they bend light in very interesting ways. They're one of the most complex lenses you could prescribe. And so when you start getting into higher powers, you're adding all these other things that you're not knowing how to control. And so I use them judiciously. And that's probably the end story. We use them a lot for testing, but prescribing them, I like to be pretty careful about what we expect from them. So they certainly have a place, but they're not the magic bullet they are sometimes made out to be.
Well, just to go back to vision therapy, just briefly, do teenagers and adults respond differently in terms of like their adaptation? Like, do younger brains adapt more quickly than, let's say older adults?
Good question. I think sometimes when we're dealing with an adult, we're dealing with a vision problem that may well have started earlier and they've just carried on through. Broadly speaking, we don't see age as a barrier to benefiting from doing vision therapy when you need it. I think my oldest patient would have been 89. So you kind of go, sort of age is not a barrier, that old cliche. Certainly things change though. So if you're talking about adults, in my vintage, where we're at that kind of age where our focusing flexibility is naturally declining, and it's not because of a dysfunction, it's because of just the lens inside the eye getting hard, and so it doesn't change shape anymore. So that alters how someone might be expected to respond to some of the activities we do. So it means that some of the activities we're using it could be just we have to label the instructions a bit differently for them, or have them pay attention to something a bit different as part of the therapy process. So I guess the short answer is, there are variations, but the overall theme of what we're trying to achieve with vision therapy based on age is fairly similar. So the younger kids, you might be working with some general eye movements that are part of their binocular visual dysfunction. Often, if we're able to catch kids early in the process of going down the path of developing some binocular dysfunction, we might avoid needing to do vision therapy, because we can kind of short circuit what we think the process is why they're heading down that way. And so I guess that's another aspect that might be different with kids, is that we get in early, then we might be able to change the path.